So Spain is one of the European countries, and in hepatitis B, Spain follows the ISEL guidelines. ISEL has released 3 different guidelines, the first in 2009 and the last one 5 years ago. And these guidelines are mainly focused in diagnosis and treatment criteria. I think what is good of ISEL guidelines was the simplification in treatment indications, simplification in all of the guidelines based only in elevated ALT levels and HBV-DNA higher than 2,000 international units for both, for E-positive and for E-negative patients. The treatment recommendations were oral antivirals, and in the guidelines, recommendation of stop treatment was when surface antigen loss has happened, except in the last guidelines that suggest to stop in some E-negative patients. Now, ISEL is working in a new guidelines. The chair of these new guidelines is Markus Convened from Hanover Medical School. And this ISEL guidelines, the proposal is very similar to the WHO guidelines using a Delphi process, but I think a simplified Delphi process. And I think for the first time, these guidelines have also representation of other countries outside Europe. And the goals is to look for a simple algorithm for initial evaluation and monitoring of non-treated patients, even simplify more the algorithm for treatment indication, working a bit more on stopping nukes, and a section on prevention that usually ISEL guidelines don't touch prevention. And we expect to have these guidelines at the time of ISEL Congress in next June. What about Spain? And I think this is true for other European countries. We have usually national plans for hepatitis C, guidelines for screening for hepatitis B. But if you look for hepatitis B, there is no strategic plan, only for hepatitis C, no B. And now we are developing guidelines for screening. These guidelines for screening are under review and are focused particularly in high-risk populations. Spain, and I think this can be applied for Europe, has a national health care system that usually guarantees universal coverage and free health care access to all Spanish nationals, regardless of economic situation or social security network. But we have 70 different autonomous communities. And each of these autonomous communities is responsible for offering integrated health service to the regional population throughout center service and establishment of that community. What does it mean? That means that each community applies in a different way the national plan, and some communities are more permissive in screening and treatment indication than other communities. In addition, each of these communities has released microelimination plans or elimination plans that sometimes disagree with another community. For example, in the north of Spain, in Galicia, there is screening for a segment of population using pools of RNA for hepatitis C. And other communities restrict screening only for vulnerable population. So in a similar way that other European countries, and this is for the ISEL Lancet Commission, I think the main limitations are particularly in the coverage of harm reduction programs and the the prescription of treatment is usually restricted to the hospitals, at the hospital level. And we have seen previously the importance of community prescription. And in the majority of European countries, prescription is restricted at the hospital levels. So what are the implementation challenges? One is the fragmentation of our healthcare system, and sometimes with suboptimal coordination between primary care, centers of addiction, hospitals, and this means that usually even having electronic records, because the electronic records are different in different settings, this cannot be connected, and we cannot have strong data to be sure how it's going elimination. The other challenge in Spain, we don't have a Sunak. We don't have a prime minister that have this, or at least say, has a long-term political decisions. We are working with short-term political decisions. We have barriers to access to diagnosis and treatment, particularly for vulnerable populations, for illegal immigrants, for homeless, for drug users, for all of these people that need treatment and diagnosis and screening at community level. And I think this is one of the most important barriers for elimination. We don't have enough financial support for disruptive technology. We don't have tests to do a screening at community for hepatitis B. There is a lot of tests for hepatitis C, but very few for hepatitis B. And it's important to develop this test. And in addition, we have financial fragmentation between the central government and the autonomous level that usually don't help to these implementation plans. And I would like just to finish just saying the importance of hepatitis delta, because now we are looking at hepatitis B, but we forget hepatitis delta, and I think it's important, and ISEL has released the first clinical guidelines on hepatitis delta, and now that we are making this effort for elimination of hepatitis B, please don't forget delta. Thank you very much.